Hi, and welcome back to Pharmacology of the Synapse. In this video, we will review the non-dopaminergic based therapies for Parkinson's disease. As a reminder, Parkinson's disease affects dopamine neurons from the substantia nigra. In this image, you can see the dopamine neurons synapsing onto the striatum. The synaptic connections here are more complicated than previously described. In this brain region, you also have cholinergic interneurons and glutamatergic afferents from the cortex that synapse onto the medium spiny neurons, which are the main neurons in the striatum, in addition to the nigrostriatal dopaminergic afferents that we were talking about before. Medications that affect these cells and receptor systems can also be effective for Parkinson's disease. Here is a close-up view of the synaptic connections in the striatum. You have the nigrostriatal dopamine afferents in blue that come from the substantia nigra. There are cortical glutamatergic afferents that synapse onto the medium spiny neurons in the striatum, as well as cholinergic interneurons that synapse onto the medium spiny neurons in the striatum. First, we will discuss the anticholinergics. These were the main medications for Parkinson's disease prior to the development of levodopa. They act to block acetylcholine receptors on the postsynaptic side, meaning on the medium spiny neuron in the striatum. They can help reduce tremor, but have little effect on the bradykinesias. Their side effect profile is what you would expect from an anticholinergic, including dry mouth, memory impairment, blurry vision, confusion, and constipation. The next medication is amantadine. Amantadine can help reduce levodopa-induced dyskinesias in advanced Parkinson's disease. Amantadine is thought to primarily block NMDA receptors, so it inhibits the glutamatergic input from the cortex. However, it also affects other receptor systems, including blocking dopamine reuptake and increasing dopamine and norepinephrine release. Amantadine's side effect profile is similar to the anticholinergics. Other therapeutic targets for Parkinson's disease include adenosine A2A receptor antagonists. These receptors co-localize with dopamine receptors on the inhibitory pathway in the striatum, and blocking A2A receptors may help reduce the activity of the inhibitory pathway. Anti-apoptotic agents may help reduce dopamine apoptosis and cell death, and antioxidants can help reduce oxidative stress, which is thought to contribute to neuronal death. Neurotrophic factors, such as glial-derived neurotrophic factor, can help promote the survival of dopamine neurons. However, administration of these factors is an issue because they need to be administered directly into the brain. Other therapies include non-pharmacological therapies, such as deep brain stimulation, which stimulates the activity of neurons near the implant. You'll see a video on deep brain stimulation for the treatment of Parkinson's disease in this week's materials. Lastly, future therapies may include gene therapy or stem cell therapy to help replace the lost dopaminergic neurons in the brain.